This is such a privilege and an honor to be able to speak to the SMA. Have a lot of respect for such a storied institution. My former chairman, Lee Nesbitt, from LSU Dermatology in New Orleans, spoke very highly of SMA and the Southern Medical Journal and your history. And one of our wonderful nursing staff, Rhonda Hatter, was on staff with SMA for many, many years and speaks very fondly of her time with you as well. Dr. Clem Cotter is the one who recruited me to come give a talk, and I was definitely enthusiastic to do so because I love what I do. I love speaking about dermatology. I love seeing our patients and treating such a variety of conditions. So my impetus for this talk and the drive is to kind of cover many things that we would see day to day, and making sure to update you on what's going on in our field and many of these things that we do all see day to day. So I trained at UAB for medical school, then returned home to LSU for dermatology, and then came back to Birmingham, where I've been in private practice in the Birmingham area with Shelby Dermatology and aesthetic dermatology. Birmingham's been a wonderful place to be, wonderful place to learn. And we have a lot of different dermatologic conditions that come our way at Shelby Dermatology. So some of the pictures you'll see in here weren't found in the original PowerPoint that was submitted. Some of those are from private collection and just out of respect for the patients. And I wanted to keep them just exclusive on here. So, but most of what you'll find in the handout is contained in the presentation. I've had a few updates here and there. So let's get started. I do speak for AbbVie. They're the makers of Humira, or adalimumab, which is a biologic used in psoriasis, along with other conditions. So without further ado, we'll start off with psoriasis. And as you can see right here, this is kind of your classic presentation of plaque psoriasis, elbows and knees. It's where I'm always going to if I'm suspecting psoriasis. And it can show up in areas of trauma, areas that have been previously traumatized, as this tattoo is right here, a phenomenon called Kebnerization. And classic white micaceous scale on a thick erythematous plaque. So where have we come in psoriasis? So for many years we thought this was just a problem with keratinocyte maturation. Keratinocytes are the scaly cells on the top of the epidermis. Perhaps they just had a hard time coming off, they weren't maturing correctly, and so many therapies for many years were aimed at treating it in that way. And eventually, as cyclosporin came out in the transplant world, they found patients that had psoriasis did quite well on, their psoriasis cleared quite well while they were on their cyclosporin to maintain their transplant. And so that kind of set off a trigger in some to say, what's the immune mechanism going on? And so further studies led to the idea that perhaps this is a helper T cell phenomenon, specifically the helper T cell type 1. And then biologics kind of developed along that line. Our first biologic medicines that came out were meant to treat that arm of the immune system, the helper T cell. Those have since come off the market. What ended up happening is more studies were performed, and now we have come up with the idea that IL-23 and the helper T cell 17 are the ones that are involved. Really, psoriasis, when it comes down to it, is a complex interplay of dysregulated innate and adaptive immune systems in the skin. It's very hard to pin down the exact mechanism going on. This is kind of a busy slide right here that I borrowed from a Lancet review. As you can see, in those that are susceptible to psoriasis genetically, along with the triggers, as you can see here, the keratinocyte, which is immunologically active, releases cytokines that gets a cycle going with TNF-alpha that involves other immune players that eventually release a cytokine IL-17, and then part of the innate immunity where our dendritic cells present this to the lymph node, to our cells there, and develop the Th17 line that then express IL-17, and you get this loop of inflammation, scaliness, which you see clinically as psoriasis. And our aims therapeutically have gone this way, and I truly think we are in a wonderful era for our psoriasis patients right now, as I'll delve into. So the different types, you have plaque, guttate, inverse, pustular, and erythrodermic. Erythrodermic can be one of our dermatologic emergencies. Sometimes it gets so severe, these patients need to be hospitalized with fluids and supportive care. This next patient right here exhibits 3 of these types. You have plaque psoriasis, guttate, and pustular psoriasis happening right here. This patient right here is a good example of what happens when systemic steroids are used to treat psoriasis. Certainly systemic steroids are a wonderful treatment for psoriasis until they stop working, and then a rebound flare can occur that can be very severe. This patient was treated at the ER several times over with systemic steroids and developed this significant eruption of guttate, palmoplantar pustular psoriasis, and exacerbation of his already present plaque psoriasis. Comorbidities. This is something that dermatologists have been looking at extensively over the last decade to decade and a half, as we started to kind of see that there are other conditions that seem to be associated with psoriasis. We've known psoriatic arthritis has been associated with psoriasis for many, many years. But we started to kind of notice that some of our patients had cardiovascular disease. And so trying to put those together, many studies have shown epidemiologically that there is an association of psoriasis with cardiovascular disease. Now, psoriasis is not in and of itself an independent risk factor, like we think of our classic risk factors in cardiovascular disease. But we do know that in patients that have severe psoriasis, particularly young, severe psoriatics, that they have a higher mortality related to cardiovascular disease. So it has been somewhat incumbent upon us, I think we've been slow moving in this, to be honest, that this is something that we need to be counseling our patients on, making sure that with their primary care provider or cardiologist, that they are being screened for the appropriate risk factors with cardiovascular disease. Me personally, when I see a young male about my age, 30s, 40s, with severe psoriasis, and I'll define severe psoriasis in just a little bit, I'm mentioning this to them, that this is something that they need to take seriously. Certainly that's an age group that, and I throw myself in here as well, we don't tend to jump over to a physician all that much to get cared for. So I want to make sure that this is something that's on their mind, because certainly this is something that we are trying to elucidate more and more. Obesity, diabetes, these are other things that could be associated. Recent studies have shown the association of diabetes with psoriasis. And depression, of course, especially when you have a patient who's got such severe psoriasis covering much of their body surface area. It is certainly affecting their mood and their quality of life in a very debilitating way. So our treatment goals in psoriasis, as we kind of look at the different treatment end goals that we have. Different studies look at the PASI 75, PASI 90, or PGA score. These are scores that were come up for clinical trials studying psoriatic disease. They're not very clinically useful, but they are the currency that's out there in how we judge the different medications and how well they work. I think that this is much more clinically practical. This is this body surface area. So we can look at a patient and see that maybe just their elbows and knees are involved, and that's less than 5%. It's a mild disease. But perhaps they have involvement of their back, they have involvement of their scalp too, along with their elbows and knees. Well, now you're looking at 5 to 10%. That would be a moderate severity. And then somebody who may have greater than 10% would be considered somebody who is severe. However, severity is certainly in the eye of the beholder. Somebody who has only palmar plantar psoriasis but has very difficult time writing because of the pain or working, well, that's severe psoriasis, even though body surface area is certainly less than 5%. Certainly genitalia involvement, that's something else that we could define as severe involvement. So again, it's something that we are working on as a field to make sure that we do classify psoriasis beyond just what can be seen, but also how it's affecting the quality of life of the patient. But our treatment goals are not only to clear disease, skin disease, but also to protect the joints. As I showed in this picture right here, this is arthritis mutilans, thankfully very rare in endpoint of psoriatic arthritis, but exhibitive of how bad the arthritis can be in these patients with psoriatic arthritis. So I do make sure to ask all of my psoriasis patients about joint disease. I'm asking them about stiffness in their fingers and their toes. I ask them about heel pain. I ask them about neck pain, especially after long periods of inactivity or after they've woken up in the morning. And does that get better as they get going? So several different treatments, many of these you're aware of, are tried and true, certainly topical corticosteroids and calcineurin inhibitors. I'll touch a little bit more on the calcineurin inhibitors when we touch on atopic dermatitis. But topical corticosteroids are still a mainstay, for sure, of treating our psoriasis patients. These are something that almost every psoriasis patient is going to be given to treat their skin disease. For mild patients, this may be all that they need. Certainly for patients that have severe psoriasis, I still feel like they need topical corticosteroids, so along with their other systemic therapy. Phototherapy is something that we still use, certainly a very effective therapy for even our very severe psoriasis patients. It just can be very difficult for many patients to make it over to the office for their light therapy, and so there are some hindrances there that can make it a difficult treatment for somebody to undergo. And so we have, of course, other treatments that we can use systemically, our traditional as well as some new oral agents. Our biologics, which I'll touch on in depth a little bit, and then tonsillectomy, which I'll touch on that neat therapy in just a little bit. So our conventional oral meds, methotrexate, still certainly a mainstay of our treatment for psoriasis. In fact, for anybody who's got moderate to severe psoriasis who is considering a systemic therapy, in my practice, more than likely are going to start on this. I don't feel that it works as well as the biologic medicines, and I think in the long term there are adverse events, particularly with liver toxicity, that we do have to worry about. But because of certain regulations and the hoops that we have to jump through to get our patients medicine through insurance, would like us to start with some conventional therapies, and methotrexate is a great place to start. We have a lot of experience in it. It works quite well. And I have a lot of patients who, after they've been on methotrexate, and I plan on switching them over to one of our biologic agents, say, "Doc, this works pretty well. I'll just go ahead and stay on this," and we'll do that. So we also have cyclosporin. This is not one that I use quite as much. This is one of our best oral agents for quickly reducing the psoriatic disease. This is something, if somebody were to come to me and say, "Doc, I've got a wedding in about 2 months. I need all of this psoriasis cleared before then." That's a lofty goal, but cyclosporin can do that. Now, cyclosporin should be used in the proper patient. It certainly has its adverse events that, particularly on the kidneys and with blood pressure, that we need to be careful about. And so it's limited in how long we can use it in a patient, but it's a very effective therapy. Acitretin, the brand name is Soriatane. This is one that we're not using quite as much, but in the right patient, it can be quite useful. Fumaric acid esters, this is not anything that's used in the States. It's used more in Europe, but it's an effective therapy as well. And then we have new oral medications. One that has gotten a lot of airplay on commercials is apremilast. The brand name is Otezla. It's phosphodiesterase inhibitor. In my experience, I will say it does work. I don't think it works as well as our biologic medicines, but this is a medicine that is actually quite safe. This is one that we do not have to monitor with lab work quite as regularly as we do with methotrexate or cyclosporin. It has its adverse events, nausea, diarrhea, that can be overcome, but patients do tolerate it quite well, and I have several patients that do like this medicine because they want to avoid the biologics. And then tofacitinib, the brand name is Xeljanz. It's approved for rheumatoid arthritis, is currently still, FDA is reviewing the studies for psoriasis, but has shown to be effective. It has its own adverse event profile as well, but this could be something that when people are scared of using the biologics, which are shots, oral medications are something that they may prefer to use. So biologics, I feel like this, I say this all the time, our psoriatic patients are winning now because of these. This has really changed our landscape of treating psoriasis. What used to be a disease where we would cheer being able to clear somebody 50%, our goals are coming close to complete clearance because of this era we're in for biologics. These medicines are tolerated very well. They're quite safe, and they're quite safe compared to some of those earlier conventional oral medications that I mentioned earlier, like cyclosporin or methotrexate. Certainly, opportunistic infections are something we need to watch out for these patients, but we have patients that are just, their lives are changed because they've been on this medicine. Starting with some of the ones I mentioned earlier that are off the market now, the Th1 players, Alefacept and evolizumab, those are not on the market anymore. They gave way to the TNF-alpha inhibitors, which are still on the market and work quite well. You have etanercept, adalimumab, infliximab. There are some others out there as well, but these are main ones that we use in dermatology. After that, IL-23, 12-23 inhibitors came out. Ustekinumab is the exemplative medicine for that. This is the medicine that really sparked new pathophysiology for psoriasis. What was originally meant to go after the Th1 arm of the immune system with IL-12 was found that actually why it worked so well is because it went after IL-23. And so that led way to IL-23 inhibitors, which are going to be coming out starting next year. IL-17 was also found to be a strong player in psoriasis. And so secukinumab and ixekinumab, which have now been out a little over a year for secukinumab. Ixi just came out this year. And then we have an IL-17 receptor inhibitor that'll be coming out probably early next year. And the bar has been raised with each of these medicines as it has come out. This picture right here is a patient who's on adalimumab, or brand name Humira. And you can see this is a PASI improvement of 95. Their original score improved 95%. And you can just see how severe the disease was and how clear they are now. These medicines are meant to take indefinitely. They are tolerated quite well. Many of these medicines have been out for 10 plus years. Certainly have patients within registries that we are able to watch for any new events. It's one of the reasons why some of these other medicines have been pulled from the market, because of new adverse events that have been reported as real-world use has occurred. But as these have shown average PASI 75 scores, and that's an improvement of the PASI score by 75%, of anywhere from 60 to 70%, we're starting to see now improvements of 90%. We're starting to raise the bar where these IL-23 inhibitors are going to be coming out next year or the year after. We should expect nearly complete clearance for these patients. And with those goals in mind, compared to just a decade and a half ago when we were cheering a 50% improvement with methotrexate, really is remarkable. I think we are really in the era of biologics for sure within psoriasis, and it has really made a difference in the lives of these patients. Not only that, especially TNF-alpha inhibitors are wonderful treatments for psoriatic arthritis. They're going to treat the joint symptoms incredibly, as well as protect the joints from the destruction, like the picture I showed earlier of the arthritis mutilans. Tonsillectomy, why would I throw this on there? Well, we know that guttate psoriasis is something that we can see after a case of strep throat. It's true that patients that tend to have eruptions of psoriasis after chronic tonsillitis or many cases of a strep upper respiratory infection, if you were to undergo tonsillectomy, you can treat their psoriasis quite effectively. And this is a study that actually just got published this month in our main journal that showed they specifically found the genetic cause of these patients with this haplotype, and found that those patients who were homozygous for this haplotype in their immune system had an incredible reduction in their severity score of psoriasis. This is certainly an option, especially in the pediatric realm, where pediatric psoriasis, our hands are tied somewhat in terms of many of the treatments we can give, but certainly tonsillectomy is an option that is used quite often in the pediatric population for patients that have chronic tonsillitis. I thought this was an interesting thing to throw in there. I can't say that I've referred any patients so far for this, but this is certainly something that I'm considering as we get more data for an effective treatment, especially in pediatric population. I throw hidradenitis in here. This is a devastating disease of just continual abscesses, inflammatory nodules, leading to scars and sinus tracts within the intertriginous zones. It's the axilla, inframammary area, genital area. These are patients that are misdiagnosed often as having just dirty skin, recurrent staph, sometimes being admitted into the hospital for IV antibiotics, when really what's going on is not necessarily an infection, but a disease called hidradenitis suppurativa, which the pathophysiology of that is very complex, certainly related to some of the things that are involved with psoriasis, and some of the IL-17s and 23s are involved there too. But traditionally, they got well when we gave them antibiotics. So of course we thought this is, a bacterial disease. And they still do quite well using antibiotics. The amazing thing is when you got a course of antibiotics for about a week or two, that's about how long a flare lasts anyway. So we know that antibiotics do play a role in treating these. We know that surgery is still a wonderful treatment for these. But the reason I highlight this is because biologics have now touched this. We now have adalimumab, also known as Humira, that is available. It's the only FDA-approved treatment for hidradenitis suppurativa. And this has also become a life-changing treatment for these patients. This is a disease that is unpredictable. You do not know if you're going to wake up the next morning and you're going to have a new painful abscess in your axilla, and you've got to go to school or work in pain. Don't know if it's going to smell, drain. Some of the worst patients I've seen have been patients that have had to wear diapers because their disease is so bad. So to have an option available has been really remarkable for these patients. Adalimumab has now been approved for. It's been approved for a little over a year now for it. It does work quite well. I would not say that it's on par in terms of how well adalimumab works for some of the other conditions, but it is certainly something that works really well. In the studies, they did study it with systemic antibiotics and found that you've got greater efficacy with that as well. Anakinra, which is medicine actually used for rheumatoid arthritis, has also been studied and I think is within a phase 3 study right now for treating hidradenitis. Then I'll switch over to another common scourge that we see in our office, and that's atopic dermatitis. Kind of a classic presentation right now. This is a very severe case, and a young boy I just saw last week, where covering almost his entire body. It will develop into what this young man has right here, and not all atopic children will develop into a chronic atopic patient as they grow older. I would say severity is something that can correlate with whether or not they would continue to have that into adulthood. But it does tend to transition from just the severe case right here all over the body, as you see in this young patient, to kind of a limited case of just being in kind of flexural areas as they get older. So atopic dermatitis, we know it's this recurrent itchy eruption. It can be mild to severe, as just showed with those pictures, that usually does start in childhood. We see it quite often. It may progress into adulthood, as I said. Pathogenesis of it is very confusing, something that's still being worked out. Some people say, is this more of an outside in? Is this more of an inside out? And what do I mean by that? Are there genetic defects in the skin barrier that are leading you to be susceptible to irritation, leading you susceptible to microbes and other things that can get in and wreak havoc? Or is it an immune response that causes the skin barrier disruption that then leads to the disease? Well, to be honest, and what we've seen so far, it's probably both. Okay? We know that treating the immune system for this works. We know that treating the skin barrier works. And so our goals have been along those lines now for years. So topical treatments, mainstay, this is just a simple treatment, are emollients that we can find over the counter, okay? And there was a wonderful study, a couple of them that came out in the last few years, where you have patients, and we know these patients. Their mom had atopic dermatitis when they were growing up. Their sister has it, and now it looks like baby brother's having it too. Well, there was a wonderful study that's just come out in the last few years. We may actually be able to prevent the development of atopic dermatitis in those patients that are going to be susceptible to it. And again, we can predict this because of just family history, okay? So daily use for the first few months of life is shown to significantly reduce the development completely of atopic dermatitis. Corticosteroids, certainly a mainstay. Calcineurin inhibitors I had mentioned earlier in psoriasis. These are things like pimecrolimus and tacrolimus, also known as Protopic or Elidil. These are wonderful medicines that can be used to maintain clearance in these patients, because these are patients who are miserable. They're itching all the time. They can't sleep. Their parents can't sleep. You're doing all that you can, and I have to encourage the parents all the time, look, you're doing the best you can. This right here, this is to be expected. This is going to come and this is going to go, and you're doing a great job, okay? And they need to be told that, because it is very difficult. We have new medicines that are coming out. Crisaborole, which is actually a completely new mechanism of action using boron in a molecule, is going to be something that's going to be coming out probably early next year, maybe spring next year. A topical phosphodiesterase 4 inhibitor that's going to be, basically be on par with some of our mid-potency steroids from the studies that I've seen. Tofacitinib, I mentioned Xeljanz earlier, the brand name for this. They're coming up with a topical formulation of this that's also shown to be very effective. Phase 3 has already, I think, been completed or almost done, has been approved. Systemic treatments. Rarely will I use systemic corticosteroids for atopic dermatitis patients. They rebound so badly after I give them a course of Prelone syrup or even prednisone, sometimes a steroid shot. I feel like they can rest on their laurels because, and certainly look, sometimes you need this lifesaver, and you do. And so I definitely think there are times that we can use it. But I feel like this can really make their atopic dermatitis worse, very much like I had mentioned earlier with psoriasis, where it can make their psoriasis worse in terms of a rebound. So instead, if I'm going to use a very intense therapy when a patient first sees me, I like to use an intense topical corticosteroid treatment with wet wraps, and I have a handout that I give my patients on how to use that. And it can be quite effective and work as well as systemic steroids, just using topical steroids by placing it on the skin along with wet dressings, then dry dressings at night. We have new antihistamine. Just found out about this whenever I was doing my research for this talk. An oral H4 antagonist that's currently in a phase 2 study out in Europe. That's shown to be very effective for our atopic dermatitis patients. For those severe patients that you want to use some systemic steroids on over and over again, that's when you need to start thinking, okay, this may just be going beyond using topical emollients and corticosteroids. You need to start thinking about methotrexate. Cyclosporin is a wonderful medicine for atopic dermatitis. I don't use 6-mercaptopurine or Imuran all that much for this. And then, of course, I'm mentioning biologics. I think because of the success that we've seen in psoriasis patients, I think we are getting into the biologic era in atopic dermatitis. This is upon us, and we're quite excited about it. Dupilumab has been approved, and it will be coming out in the spring of next year. This focuses on the T helper type 2 arm of the immune response, going after the IL-4 and IL-13, and it has been incredible. There have been some of the studies, did it happen in Birmingham at one of our allergy offices that we work with, and I've talked with some of the physicians there, and they say the same. This is going to be something that I think is really going to help out our patients. At first, I think it'll only be approved for our adults. Really, the children need it, and I do believe the studies are ongoing for that, if not already there. But as you can see, we have now come up with these severity scores for our atopic dermatitis patients, much like we have for our psoriasis patients. And you can see the improvement that has happened, nearly 50%, or getting at least 75% improvement. But just also that itching, the anxiety, the depression that comes from it. This is going to be something that I'm really hopeful will be very similar to our revolution in psoriasis. Will also happen in atopic dermatitis. There's another one that'll be coming out probably 2018 called nemolizumab, and that's going to be going after IL-31, which is involved in pruritus. So far, just the phase 2 studies have been finished. But again, I hope I can start saying that our patients are going to be winning here because this is really going to change lives. So now we'll switch gears and go to something that we all know very well and we see in our office every day, and that's acne. Okay, kind of a couple of spectrums here. This is certainly one that's, I would call this a severe patient because of the scarring. This is a patient that now he's on his second course of isotretinoin, and just because he started to flare up again in a significant way. This is a patient right here that my fellow residents from LSU knew quite well. He was probably one of the worst skin patients that we had. This was not nearly the extent of his disease, as terrible as this is. He had what's kind of considered a follicular occlusion triad, where he had hidradenitis suppurativa and dissecting cellulitis as well, his scalp. So he had involvement up here, he had involvement on his body. That was just incredible. A lot of the biologics that I mentioned earlier were being used off-label on him just to see what we could do to help him. So acne, very, very common, 85% of teenagers. I think this 12% of adult females is probably underreported right here. I think this really does affect our females a lot. The pathogenesis, very complex, not as straightforward as a blackhead or a whitehead starting, and then that being, not allowing the bacteria out, and so it forms a pustule. I think that there's a complex interplay happening here of that blackhead from the follicular hyperkeratinization, the P. acnes that are colonized in our skin, the sebum that is being produced, which is one of the reasons why teenagers are so susceptible, because when puberty hits, the sebaceous glands are induced and produce a lot of sebum. And then, of course, there's innate and acquired immunity involved, too. We used to dispel the myth of chocolate and acne. I think we may be getting to the point where we can't dispel that myth anymore. We've seen that if you are able to send the insulin levels up rather quickly, that can affect acne. And so I am talking to my patients about their diet, specifically saying, well, stay away from the sodas. Actually, skim milk is one that you have to watch out for too, apparently. But even some of the other parts of your diet that can really increase the glycemic index are things that you have to be careful for. So our topical treatments, mainstays are retinoids. These are things like tretinoin, adapalene, tazarotene. Wonderful medicines, still a tried and true cornerstone therapy for it. News here is that adapalene is going to become over the counter, which is, I think, great news for our patients. Okay, we have so many patients that we see that can't get the medicine. I feel like they're certainly seeking out other sources of treatment that I don't feel work as well, and so I love that they're going to be able to have first over-the-counter access to this. This is going to happen in January. Adapalene, also known as Differin, is going to be available over the counter in their 0.1 formulation. Antibiotics, still a great treatment for acne. We have developed some resistance here and there. I'll touch on that in a little bit when we talk about the systemic antibiotics for acne. But we've developed some resistance within the topical antibiotics. We can't use topical erythromycin really anymore for acne because a lot of P. acnes is resistance to it. Dapsone has come out as a topical formulation. The brand name is called Axone, and it can work quite well too, and it's tolerated quite well. As we know, some of these topical medicines can be a little irritating and take some getting used to, as I always tell a patient. Salicylic acid and benzoyl peroxide, still wonderful parts of the armamentarium against acne. And then our systemic treatments right here. I think us dermatologists have a black eye here in terms of antibiotic usage for acne. We're certainly, we've left some patients on antibiotics too long. And the CDC, of course, has called us, all of us out as physicians with regard to this, but we know as dermatologists that we should not be leaving a patient on antibiotics for an extended amount of time. And so the call to action that we've all heard about how resistance is real. I was talking with our local acne expert just last week, and she said that she's already seen a tetracycline resistant staph. Maybe somebody else in here has already seen that too. That worries me because doxycycline is a wonderful medicine for acne, but it's also a wonderful MRSA medicine. And so we need to be careful here. And so our calls and guidelines that have come out recently for acne, and there was recently published guidelines in our literature this year, are saying we need to limit our courses. I think that a low dose, kind of below the MIC antibiotics work quite well. Here I am looking 3 to 6 months. I'd rather not put them on there that long. I always get my patients back here about 3 or 4 months to see them, see how they're doing, and I'd love to stop using the antibiotics. And so we need to refer to our alternatives. The This is where our evidence-based medicine helps us. Systemic review not too long ago, a meta-analysis of reviews, has shown that oral contraceptives in our females at 6 months is equivalent to using antibiotics systemically for the treatment of acne. And it works quite well, and you've seen it. It is a very good treatment for acne. And then, of course, isotretinoin, which I'm very comfortable using for our patients with acne. Now, we know the teratogenicity and the category X that it is. We also know the association that it has with depression, which is very controversial. But that being said, I do appreciate that the FDA actually has this iPledge system, which is like a registry for these patients. The only way they can get this medicine is if they are enrolled in the iPledge system. And if they're a female, they must be monitored for pregnancy. And so our staff is very good at signing them up for this iPledge program. We check a urine pregnancy test every month, and the patient is allowed to get the medicine month to month. And usually it's a 6-7 month course. If they're female, as long as they have been on 2 forms of birth control. Abstinence can be one of those. And of course, they're not pregnant, okay? And this has worked quite well. Instead of, hey, take this for 6 months, we'll see how you look when you come back. Instead, they're coming month to month, and we're coaching them through this medicine, which is not an easy medicine to tolerate. But as this picture shows, the before and afters, this, I think, is our miracle drug still in dermatology. I always say this, I don't cure a lot of things. I treat a lot of things. I don't cure a lot of things. But I can cure acne with isotretinoin. And it's incredible when a patient, such as this young man, comes to you and won't even look you in the eye. But as you get to know them over that time, they're coming month to month because of iPledge and because of treatment, coaching. At the end of that time, they look clear, and their personality comes out, and you get to know them. It really is. These are redeeming, wonderful, satisfying visits at the very end of their course when their skin is completely clear. New treatments coming. We're going to have topical tetracycline or topical monocycline. Trifarotene is going to be a new retinoid coming out that's going to be very selective for retinoid receptors found in the skin that thankfully may not have a black eye in terms of its black box warnings or anything like that for category X, which some of our topicals do. It is an orphan drug available right now for our patients with lamellar erythrosis. I do not have any. This is a genetic disease of significant scaling skin, but because it works so effectively, it's out for these patients. Nitric oxide. This is one of these nanoparticle medicines that's going to be coming out that has been shown just in the studies that I read and some of the friends that I've talked with to be quite effective against P. acnes. Won't induce resistance, which will be excellent as well, and works also on the sebaceous glands. And then laser treatment for this, which I think this is fascinating. I have a little soft spot for lasers. Microparticle gold. The gold is in this suspension, and it's rubbed on the skin. It localizes into the sebaceous glands, and gold is selectively absorbs certain wavelengths of light, which you are able to deliver via the laser energy, and can quite effectively treat the acne. I've seen pictures. It's remarkable. So we'll transition over to rosacea, which you can kind of see it overlap sometimes, rosacea and acne. These are the different types right here. Erythematotelangiectatic, I just call it ET. Papulopustular, phymatous, and ocular. And you can see all these pictures right here showing the various presentations right there. And we've had some great updates in our medications for this as well. Mainstays are sodium sulfacetamide, metronidazole, and azelaic acid. But our new ones that have come out, ivermectin, and this kind of came out of the idea that perhaps the Demodex mite is involved in the pathophysiology of rosacea. It still has not been found to be the causality for all patients, but certainly there are plenty of patients out there that have Demodex infestation, and we've seen them. It's subtle, these little white spicules on their skin, and they're very inflamed. And ivermectin works quite well for these patients, but also ivermectin works quite well in those patients that don't have Demodex but have rosacea. And we think there's an anti-inflammatory component there that it works quite well, and it came out earlier last year. And then bromonidine, a topical alpha adrenergic agonist that works by vasoconstriction. This is our only topical treatment for those ET patients with the flushing. I call it the Cinderella medicine because the effect wears off after 8 to 12 hours. But for somebody who has persistent flushing on their face, this is something that they can either use daily, it's tolerated quite well, or they may just use it for events. It's up to them, but it can really work quite well for them. Laser treatment is something that can also work quite well to treat the persistent flushing of rosacea. And then we do also use systemic antibiotics. This is an area where I'm very thankful that we have different formulations of our tetracycline medicines for rosacea, because these are patients that need to go off and on doxycycline. So there is a low dose, extended release version available out there. It's very difficult now to prescribe for them, just in insurance doesn't like to cover it, but very effective, especially using it here and there for treating not only their papulopustular rosacea, but this is the treatment of choice for ocular rosacea as well. And then isotretinoin, at times I'll use this for severe rosacea patients. Certainly after we've tried so many things. You have to be very careful because the side effect profile of isotretinoin does irritate the skin significantly, which can exacerbate their rosacea. So we talk about that and we coach them through it, but I've seen great results for patients with severe rosacea on isotretinoin. So switching gears a little bit over to dermatitis, specifically contact dermatitis. This is probably one of the most common things that I see in my practice, and this is a good example of when a patient comes in and I'm looking at them and I see, okay, bilateral symmetric axilla involvement, and I ask them to raise up and I see that it's sparing kind of the vault of the axilla right here. So immediately my mind goes to, okay, bilateral symmetric, this is likely an allergy to something. Specifically, well, my shirt's kind of sitting right in here, so it's sparing the vault, so it's probably not an antiperspirant or a deodorant. And the shirt's sitting there, so it's probably something related to textiles. Again, this is just what's going through my mind as I'm seeing this patient. But sometimes you don't get them that clear cut, and they can be difficult to figure out what the cause is. But kind of jumping into contact dermatitis here, you have two types. You have allergic, which I always relate to my patients. You know what this is, because you know what poison ivy is. Everybody knows what poison ivy is. That's your classic allergic contact dermatitis. But you'd be surprised at that shirt that you've been wearing forever, or that shampoo you've been using forever, all of a sudden takes a turn on you and you develop an allergy to it. And that can happen. We know that how long it can take, who knows how long for somebody to develop an allergy to poison ivy. Well, the same thing can happen with a product that you've been using or something you've been wearing. And the list goes on and on, different causes. Irritant contact dermatitis is probably what I see more. Think of irritant contact dermatitis as almost like self-induced atopic dermatitis, where the barrier is disrupted by various insults from different chemicals or physical insult, or a combination of those. We see it in healthcare workers all the time because we wash our hands a lot. And when we wash our hands a lot, we strip things from our skin over and over and over again. And that next time that you put on a detergent known as a soap, you can induce an irritant contact dermatitis. So, and then certainly ambient humidity outside can make a difference too. And so this time of year, we see this a lot. It can be very difficult to distinguish the two. Sometimes, we'll do a biopsy to kind of help us point us in the direction of whether or not this is kind of an allergic contact dermatitis. And then I love to do patch testing on these patients that we need to figure out more, and you can really help them out tremendously, especially for patients who have been struggling with this for a long time, and they had no idea that it was that deodorant that they were using, or it was the topical medicine they were using. Just as an aside, we hardly use Neosporin because of the contact sensitization of neomycin over and over again. We recommend polysporin, but really you don't even need an antibiotic ointment when you're trying to heal just either a simple abrasion or something like that on the skin. It's the ointment that it sits in. It's the vehicle that provides the matrix that things heal really well in. There have been studies that have shown that. So we just recommend Vaseline. But if somebody wants to do an antibiotic ointment, and at times if there is impetigo or something like that, we will prescribe either a mupirocin or discuss some other antibiotic or antiseptic treatments. Treatment of choice, of course, still for this is topical steroids for both of these. Got to be careful. There are some classes out there that can actually cause contact dermatitis, so you carefully choose which ones you need. Chronic idiopathic urticaria, this is one that also biologics have kind of changed our treatment for these. These are patients that get hives over and over and over again. And it can be very difficult to figure out what the cause is here because the causes are endless, and of course what's in name is idiopathic. About half the time that is the case. It's wonderful when you can have a patient come in and one of the first things I do if they tell me they have chronic hives is I get a Q-tip out and I scratch their skin just lightly and watch to see if a hive develops within that scratch over a few minutes, and that would be dermatographism, or kind of a pressure-induced development of urticaria. And you could even put your favorite school on there, LSU, and it'll bring up. So, but the classic treatment for this is antihistamines, and they work, and they do. But sometimes you need a little bit more medicine. These can be miserable patients. And thankfully, omalizumab, also known as Xolair by its brand name, is now approved for chronic idiopathic urticaria. And this has been game-changing in here. These patients have just really, really benefited from this. And if they also have asthma, it helps out with that as well. So, onychomycosis, we've seen kind of a resurgence in this, so to speak, because topical medicines are out now for this, and we've seen them advertised. I always like to confirm before treating. I've been fooled a lot of times that it's just trauma to the nail and not fungus before I start medicine. And some of these medicines are expensive, some of these medicines have some effects. And so I want to carefully choose what we are going to use for these patients. But our traditional treatments are our systemic antifungals right here. And they have various dosing regimens that we can use. I'll touch on one in just a little bit. But we have new treatments out, efinaconazole and tavabarol. You can see that borol right there. I had mentioned that earlier with crisaborole. This is our first boron molecule in dermatology, which is a new mechanism for us. And efinaconazole is another azole medicine. And they both work quite well topically. In severe patients, this is off-label, but I like to use both of these together, topical and systemic. Topical, you do typically need a full year of treatment. Traditionally, in a mild, moderate case, you can get away with just a few months of terbinafine. Sometimes you do need longer courses. So, going up on, I'm not giving up on terbinafine, also known as Lamisil. I think we have a lot of misconception out there about the liver injury with this. There's a lot of data that backs up that this does not affect the liver like we think it does. Now that being said, it does. It is cytochrome P450 inhibitor, and so it interacts with medicines that are also cytochrome P450 metabolized. And so we do need to be careful with our statin patients and those, and we need to monitor that. So I definitely do get liver enzymes on these patients and check them. But that being said, the data backs up that we don't see a lot of liver injury with this. It still works quite well. That being said, if leery, we can still pulse treat, okay? Alcohol takes a toll real quick on the liver as well. Patients can kind of understand that this is kind of like several drinks, but only in the day right there. And so this is something that you can use instead of constantly taxing the liver. But again, there have not been any serious adverse events related to, in terms of severe liver injury related to terbinafine. Had to throw seborrheic keratoses in there. I think we all know what these are. We all see these. This is what I always tell my patients, a very, 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 very common diagnosis, most common diagnosis I make. And I think with the public health message that we've been coming out with in dermatology in terms of changing molds, you need to come get checked out. This is why patients are coming to see what this is. Why would I bring up seborrheic keratoses? They're so familiar and we see them all the time. We actually have a medicine finally coming out for these, okay? Now, how efficacious? I tried my best to see what was available online, and it's not there yet, but the phase 3 should be coming out soon. I'll be going to a meeting in about a week that I hope that there'll be a poster on this where you can actually see some pictures, but I've been talking about this with patients now for the last couple of years, but this high concentration hydrogen peroxide topical solution more than likely won't be covered by insurance, probably end up just being formulated for cosmetic use. But I know several people line up for this. Be interesting to see how efficacious it is. It's also been studied in warts as well. And speaking of warts, it's another common scourge we see every day. Many different ways that we can go after them. This is an interesting patient we saw when I was a resident, where the wart accumulated within the black tattoo. It has been postulated that perhaps black tattoo ink can be immunosuppressing locally, and that is why the wart likes to prefer to be in there. That's, again, just a postulate, but it's interesting. So hard papillomatous papules, as you saw with the little boy I showed earlier, many different types out there. Genital warts are ones that we probably need to worry about more, and we're going to be touching on that a little, I think, in the next talk, and how they can be oncogenic. But we do have a vaccine available out there that can really be helpful in preventing this from causing the cervical cancer that it can. One of the most memorable cases I remember from medical school was a man who had involvement, had metastases to the lung, and you know, you definitely learn as a third-year medical student that you need to do a comprehensive physical exam because the primary was in the anus, and we didn't look when we first looked him over in the ER. So I certainly take these seriously. If a patient does have condyloma around the anus, I get a GI or a surgeon involved for proctoscopy, make sure that it's not involving a little further into the colon. Got to destroy wart. That's still the best way to treat it. It is a virus that's doing construction in the skin, so you need to destroy it, the construction. And so many different ways we can do that. It's listed here. These medicines right here are on label for genital warts. This is actually known as Verigen, brand name, and it's actually a botanical medicine. It's our only FDA-approved botanical medicine. They literally crush up these plants and make a paste out of it. It's helpful for genital warts. I give it to all my genital wart patients. Then you have intralesionals. We use this quite often. These are off-label treatments, but they work quite well because you have some patients that are just loaded with these warts, and you need everything that you can to treat these effectively. Actinic keratosis, as we switch kind of over to our skin cancer topics. These are kind of pre-cancers, is what I call them. Very subtle keratotic plaque right here. You have your patient that's, you can tell, walking in, knew the sun for many, many years and developed many, many pre-cancers or actinic keratoses. These have been found to be genetically continuous with squamous cell carcinoma. Many different treatments that can be used. Favorite of ours for sure is using liquid nitrogen or cryotherapy for these, directed therapy. But there are other ways you can do it. Excision, I don't really excise actinic keratoses unless I'm cutting out a squamous cell carcinoma and happen to cut out an actinic keratosis along the way. But at times they can be very thick, and it may be one of the ways to treat them. Field therapy also, and I think the combination of targeted and field therapy is the way to do it. Sometimes you have to take your own medicine, and that was me right there just from a couple of weeks ago doing photodynamic therapy, which I think is a very, very effective treatment. It results in a chemical peel-like reaction. This was me right before my skin was starting to crack. But as you can see, I'm okay now. You recover from it, and it works really well. This is a really helpful treatment for our patients that are burdened significantly with this, where we know anywhere from 1% to even 5% of these a year can turn into a skin cancer. So you can imagine if the burden is immense, that skin cancer is going to be right around the corner, specifically squamous cell carcinoma. But certainly with all that sun exposure, we know that basal cell carcinoma would be involved as well. And so we'll jump over to non-melanoma skin cancer, also known in the literature as keratinocyte carcinoma. This is something all of us are aware of. We certainly see our patients that have this. Basal cell carcinoma is not just the most common skin cancer, it's also the most common cancer, period. This is, it outnumbers all of the cancers combined. Thankfully, it's indolent, it's very easy to treat. And that being said, I'll show you some pictures where we do need to take it seriously, what it does. Squamous cell carcinoma is the second most common skin cancer, and this can be found sun-exposed and non-sun-exposed. We do have some prophylactic medicines out there that can help. I mentioned acitretin earlier with psoriasis. Really the only time that I really write acitretin now is for prophylaxis for some of these patients that have a lot of actinic keratoses. And the New England Journal of Medicine published something last year of Australia was studying over-the-counter vitamin B3, and that a randomized controlled trial showed reduction. I think more studies need to be done here to look at this, but this is very intriguing. It's something certainly to consider. So basal cell carcinoma, typical examples of it right here. I like how this picture shows the shoulders, because think about the intermittent exposure that we get, sunburns on the shoulder so often. We see these all the time here. And they can locally destroy. So I was shocked when my brother-in-law, who's an orthopedic surgeon, he sent this to me when we were both residents. And I said, "Are you sure that's a basal cell carcinoma?" He's like, "Yeah, dermatology sent it to us over at the VA." That's definitely the worst case I've ever seen. I actually never did see him, but I had to go to orthopedics for this. This is a patient I saw over at Charity Hospital in New Orleans with a significant basal cell carcinoma. So typical treatments, excise it. Other modalities we can use as well. But depending on the severity, will depend on what we choose to treat it. And then now we actually have a pill for it. And this is something that we reserve for those severe cases, like the ones we looked at earlier. But it targets a common pathway that's found in basal cell carcinomas. That's the hedgehog pathway. And it's quite impressive in what it does if they can tolerate the toxicity involved with it. Alopecia, I always say muscle spasms, Charlie horses, and they can have taste disturbances. But if they can tolerate that, and there are certainly some things we can do to help them along that way, this can really kind of hold things at bay. We've got patients that we need this for. I showed the pictures earlier. Certainly, location is key when you're treating a basal cell carcinoma. I always say, real estate matters to the patient and how we're going to treat them or how big it is. So, now squamous cell carcinoma, very thick keratotic papular plaque. These can be more aggressive than basal cell carcinomas, but thankfully, uncommonly, they metastasize. But we do have risk factors, and we're doing better, I think, at figuring these out than we had in the past, and try to stratify which patients are more at risk than others. And as you can see right here, all the different ways in which we need to worry about this. And they can be pretty severe. This was somebody who came with a patient of ours, who'd been a patient of ours for years and years. He said, "Doc, I just feel like you need to see my friend." And I kind of looked up at him. I didn't see him at first when he came in. And I kind of looked at him and it was a double take. This was severe. I thought it was basal cell carcinoma. Biopsy showed squamous cell. Sometimes it can be very hard clinically to differentiate them. Sometimes there's overlap too, pathologically. This is another squamous cell, and then this is a lady right here I saw before I even started dermatology. This was during my intern year at Princeton Baptist, who developed within kind of a burn scar that she had right here. So typical treatments, excision, but many other treatments, as you can see as well. Mohs surgery, I didn't mention that with basal cell carcinoma. I will here with squamous cell. We do it for basal cell and squamous cell. It's a wonderful tissue-sparing procedure where the patient doesn't have to go under a general anesthesia. It can be done in the office. And it really is a wonderful way to treat these in a very safe, effective, cost-efficient way. These are the patients that I really worry about squamous cell carcinoma in. I get them to see me as much as I do my melanoma follow-ups. As you can see, the incidence is so much greater in our transplant patients. And I said solid organ up there, but it's an issue with our hematologic transplant patients as well. It has been shown that if you use sirolimus instead of some of the other immunosuppressants, that perhaps that lowers the rates of squamous cell carcinoma. That would be something to communicate with the transplant surgeons on that and the transplant doctors. So now our biggie, and that's melanoma. That mole that is irregularly shaped, the one that we all fear, and we do, because this is a killer, and we'll go into some of the developments that have happened there. But as you can see, over 75% of skin cancer deaths come from melanoma. It's been a scourge, for sure, of almost epidemic proportions. Most common skin cancer we're going to see in females, or the most common cancer we're going to see in females in their 20s. Thankfully, we don't see it all that much in there, but if they're going to have a cancer, most commonly it can be a melanoma. And we know it's related to tanning bed use and a lot of sun exposure. But a lot of risk factors are involved there too. But finding it early, screening is key. So just some kind of memorable cases. I can remember when this showed up. I was an intern, that same rotation that I was on in Birmingham as an intern. Just an incredibly thick melanoma. And right here, you can see within just this pigmented macule right here, an amelanotic nodule coming out. And this is when you worry about progressing. So how do I look at these patients when I see them? You get scared when you see all these moles. And so what I do is try to get a gestalt of what's going on, focus in on those that are irregular, that are different, and really and biopsy those that appear atypical to me. When I'm doing my biopsies, I like to just use a shave biopsy. But for a melanoma, suspected melanoma, you need to get the whole lesion. And so using a saucerization biopsy, which just basically means that you're trying to kind of dig the whole lesion out, ensures it's removed adequately and can be assessed appropriately histopathologically, which I'll go over in just a second. Dermatoscope is my eyes in the room, especially for skin cancer screens. So here's melanoma right here. Here's my dermatoscope right here. Looking at the mole, and then I'm able to reveal structures that provide irregularity, a big blotch right here, regular streaks, this little bluish, whitish veil right there. These are all suspicious signs of melanoma. And then on the histopathologic diagnosis, we need to find out how deep it is, how mitotically active it is there ulceration or not, what are the margins there. And then we can do further studies for those that are equivocal. These are usually done at specialized centers around the country, but they can really tell us, are we dealing with a melanoma or are we not dealing with melanoma? Because it can be difficult to do it straightforward. And then we get our tumor node metastases staging. What's scary here is seeing the disparity between stage 1 and stage 2. Stage 3 is the presence of nodes. Stage 2, the nodes are negative, but look at the big difference in survival. So how can we tell a patient who I just found a mole on, the nodes are negative, if it was significant enough that I sent to the surgeon, and they check sentinel lymph node, how can we tell them what their prognosis is? And perhaps this is going to help us. This is something that's on the horizon for us, genetic expression profiling. We're able to see a genetic signature of these dubious moles, I guess you could say. And because of the range of progression, as I showed here, 3 to 55% of disease progression and death, stage 1 to 2. So this can give us an idea, especially in those sentinel lymph node negative patients, who is at higher risk and can affect our treatment and our surveillance of them. So treatment-wise, if it's deep, I'm going to send it off to my surgeon. And Dr. Clem Cotter, who invited me to speak here, is who I like to send my melanomas to, and also some general surgeons that work with us as well. Certainly, sentinel lymph nodes are done. Controversial, the lymph node dissection. There have been some studies recently that have shown that this does not, a complete lymphadenectomy does not extend any survival. I think more studies need to be done here, but it's certainly intriguing. But sentinel lymph nodes certainly can give us some prognostic information that can be helpful. However, it's scary to know that there are a lot of sentinel lymph node negative patients out there, 2 out of every 3 that die from melanoma. We have incredible therapies that are coming out for melanoma. Intralesional therapy, it's actually a virus, an oncolytic virus. It's tropic for tumor cells and lyses them, and then induces the immune system to fight these metastases. Radiation, adjuvant therapy, I say interferon. Some of these newer medicines that I'm about to go over are also being studied as adjuvant therapy for stage 3 melanomas, and then conventional chemos. So when it gets to this, it's certainly out of my hands. It is in the oncologist's hands. These patients are coming back to see me for surveillance. This is truly remarkable in the world of melanoma in the last 5 years. What was a death sentence is now a treatable disease. It has been incredible to see what these medicines are doing. We speak about melanoma differently with our patients now. We are seeing the successes. I think this is one of the most remarkable things that has happened in all of cancer treatment in the last 5 years. And I'm thrilled that it's within something that I deal with on a daily basis in terms of screening for melanoma. Our immune-targeted therapies are checkpoint inhibitors, and our oncogene targeted therapy for the BRAF mutant melanomas. You can look at the biopsy and tell if it's a BRAF mutant just from some tests. These immune checkpoint inhibitors are probably some of the better ones, but people are finding that combining some of these, and again, the oncologists are better at explaining this, but are finding that combination of these can really work quite well. There are some adverse effects that are kind of new in the world of cancer treatment that these patients have to deal with. When you're targeting the immune system to stay there longer, you have some autoimmune effects that are can be quite severe. In fact, there was just a recent report in New England Journal this week about a fulminant myocarditis that led to death related to ipilimumab treatment. But that being said, the longer progression-free and overall survival compared to chemotherapy has been remarkable. This is something that we used to tell patients, you're going to die in 6 months maybe from this. No longer, which is incredible. So of course it's a good time for me to jump on the soapbox about sunscreen. We know that this works in preventing skin cancer. Usually when you find your sunscreen, it's going to be a mix of covering UVA and UVB. There are physical agents. We think of our zinc oxide, titanium dioxide, and then there are organic agents. These are very good. We just don't have a lot of the good ones out there here in the US. And that's because it's been a frustrating thing in our field. They've been stuck in the FDA review. Very hopeful that the FDA will mine through this and get these approved for us. I won't deny I've gone on some trips and searched out some of these sunscreens and out of the country and gotten them, and I appreciate that I'm able to use some of them. But when it comes down to it, remember sunscreen is like a fourth line of defense. If you're going to be in the sun a long time, first of all, try to avoid the peak hours. Wear protective clothing, seek shade, apply, make sure if you're going to use sunscreen, apply it to all sun-exposed areas and reapply, okay? We've got an oral supplement out there that also helps. It's an adjuvant to sunscreen is what I call it. It's marketed as HelioCare. Excellent treatment. I found personally that it's kind of that medicine that if I take, and it's a topical, it's an oral antioxidant found over the counter, that it will significantly reduce maybe a chance of sunburn, along with the sunscreen that I'm using. Again, it's used with sunscreen. Last thing, cutaneous drug reactions. This is where we get severe hospitalized patients in dermatology. Most common cause antibiotics. You have so many different presentations, but the most common is your exanthematous and urticaria. Key thing, stop the medicine that's doing it, okay? Thankfully, a lot of these are benign. You don't have anything to worry about, okay? But certainly supportive treatment's needed as well. We're going to go over the severe ones. AGEP, SJS, TEN, DRESS. Biggest warning sign with these, is there a rash and fever? Those are the key things, rash and fever. So AGEP, this is one, thankfully, out of all those, probably the most benign on that spectrum. But you get many of these sterile, non-follicular pustules. You can see right here, neutrophilia on their CBC. Thankfully, it self-resolves. Stop the medicine. Topical steroids will speed up the resolution. Most common cause of that is antibiotics, especially the beta-lactam. This is our big one right here, SJS-TEN. We certainly worry about this in a lot of our patients that we put any medicine on. Painful skin is a key thing to ask about, and is their mucous membrane involvement. And as you can see, need mucous membrane involvement, and depending on the body surface area, can define as SJS or TEN, okay? Usually the onset happens within a week to 2 weeks of starting the medicine, okay? So it's 1 to 3 weeks, but we're always thinking usually soon. And that's important when you're differentiating this from DRESS, which I'll go over in just a little bit. But our most common offenders are antibiotics and anticonvulsants. Critical timing here. Stop the medicine to save the skin, okay? They need a burn unit care. It's controversial what works best to treat these patients, but we know we need a multidisciplinary approach at this, as you can see right here, okay? Because of all the sequelae that can happen here, okay? And there are scores out there related to age, how much is involved, certain markers on their CBC that can kind of give you a prediction of how severe this could be for them. And then DRESS, this is kind of something close to my heart. I'll go over a case really quickly with this. But basically, what looks like a typical drug reaction, exanthematous, that starts 2 to 6 weeks after you start the drug, so it's a little bit later than SJS-TEN. On the CBC, you see eosinophilia or typical lymphocytes, but they have systemic involvement, almost like they've got like a mono-like reaction with lymphadenopathy, hepatitis, but you also see these other systemic involvements that show up later. That's the scary thing about it. Perhaps a herpes virus is involved with this. It's been studied extensively. Still don't know exactly how. Perhaps the drug sets off a reactivation of this. You can see how severe it looks. You almost think TEN, but this is not. It's more biliform. Skin is staying on. It's not dusky dark. But it is exfoliative because the skin has been so affected. Many different drugs. These are our most common ones right here. This is one where pharmacogenetics and different haplotypes have been able to help us screen patients that need this. In the HIV world, this has been incredible. They've been able to screen right here, decide if the patient needs to be on abacavir or not. So, but we found this in other medications as well. Tough thing about this is you've got to stop the drug for sure and DRESS, but it may get worse. And so long tapering courses of steroids are needed, and the monitoring of sequelae, which can be unpredictable, okay? And I'll go over the cases that'll show that. 10% mortality, certainly age makes a difference here. But autoimmune sequela, a year or two later, thyroid, diabetes have been shown to happen. So because it's close to my heart, I'll show you, a case, and then we'll be done. 31-year-old black female who was diagnosed with DRESS. Typical presentation right here. This was when I was a medical student at UAB. Relapsing, remitting, like I said, this is something that can keep on going. She presented to the ER with chest pain and shortness of breath. EKG showed that she had MI, elevated cardiac enzymes, normal cath. 2 days later, she died. Histopathologically, there was a diffuse eosinophilic myocarditis. This is not her, but this was in the New England Journal of Medicine right around when this case happened. Very odd, very coincidental. And perhaps there were some clues for treatment. And you don't always get a second chance. But in this case, in a very rare case, we did. 28-year-old shows up only a few months later. DRESS. Typical presentation. Prednisone, long tapering course, but continued to have elevated LFTs. But because of what we knew before, we told her, hey, if you have shortness of breath, chest pain, you need to come immediately to the ER. And that's what happened. Same thing. Everything looked normal, just like before. Cardiac arrest within 24 hours. This time, though, a left ventricular assist device was placed. She improved over time with that, had to be on immunosuppressant medicines, and was discharged a few months later. She's continued to do well. So you learn from your cases, but this can be severe. And so because of this and because of just the incredible coincidence that it was, we had a couple of cases like that. We just kind of going quickly through some of the, this can be a spectrum. I had mentioned earlier that ipilimumab just reported this week that fulminant myocarditis could be a part of it. Again, there's something autoimmune here, something that's reactivated. Have to diagnose it with a biopsy. We talked about steroids being needed. Need our cardiologists involved for sure with this. Always tell my patients with DRESS, tell me about shortness of breath and chest pain. And of course, because of this, we published this. So I want to thank you very much. We've got a big matchup this weekend. I found this one online, but this is actually a patient of mine who developed a cutaneous reaction to her tattoo. I told her she was allergic to the Tide. So, but anyways, I thought I'd throw that one in there. But thank you very much. So.